Well, thank you for joining us today for a very special webinar focused on genetic testing in prostate cancer and what recent changes in Australian law mean for patients and families. My name is Katie Clift. Pleased to be moderating and hosting today this episode of the Prostate Podcast. And we know that genetic testing is becoming an increasingly important part of prostate cancer care. It can help guide treatment decisions, identify aggressive disease earlier, and give families important information about their own health. But despite this progress, access to genetic testing in Australia remains inconsistent. Recent research has highlighted the scale of this challenge, showing strong consumer support for broader access to testing, but also significant uncertainty among clinicians around pathways, eligibility, and delivery. And at the same time, concerns about how genetic information could be used, particularly in life insurance, have been a long-standing barrier for many people considering testing. Australia has now introduced legislation to ban the use of genetic test results in life insurance underwriting, which marks a very important step forward in protecting patients and improving confidence in testing. We're going to go through all of this in depth on the podcast today, and I'm very pleased to introduce two experts to walk us through all of these different points and more. We have Professor Haitham Tafaha, a health economist and PCFA-funded researcher at the University of Queensland, whose work has examined how genetic testing should be implemented in prostate cancer care in Australia. And Dr. Jane Tiller is a leading expert in genomics, ethics, and health law, and has played a very key role in advocacy around genetic discrimination, including recent reforms in Australia. We're very pleased and privileged to have both of you joining us on the Prostate Podcast today to dive into these topics in great detail. But let's start very simply. I mean, what do we mean by genetic testing in prostate cancer, and why is it becoming more important?
Yeah, so I'm focused very much on the preventive health side of things. I come from the School of Public Health at Monash Uni, and we are really focused on how we can start to use genomics and the power of genomic information to prevent disease. There are other pieces of work that focus on genomic testing of people with cancer and how that can be used to guide treatment, to diagnose, and to make decisions about how we treat cancer. But I'm really interested in how we get ahead and prevent cancer altogether, or at least move into early detection of cancer using genetics. And we know that there are many genes that lead to high risk of cancer, but there are a number of known genes that lead to an increased risk of prostate cancer in men. And if we know about those genes and we know about which people have variants in those genes that lead to an increased risk of cancer, we can give them increased surveillance, we can give them increased preventive care, and we can actually get ahead of this kind of cancer, either preventing it altogether or catching it at a time that is far more treatable and far more successful to make sure that people are well.
Absolutely. And Haitham, from your side, I mean, if someone's just tuning into this podcast, it might be the first time they've heard of this concept, or one of the first times of genetic testing. There's a lot to learn and know about it, specifically for men and related to prostate cancer. From your side, why is it becoming a lot more important in the space?
Yeah, this is, as you know, when I talk about genetic testing, this is important to identify abnormalities in our DNA or in patients' DNA. This is important because, as Jane said, it's important to identify people at risk of developing cancer. But I will add to that, it's also important to identify the risk for the patients themselves as well, because patients who have that abnormality or mutation, they have more aggressive form of the disease, meaning that they would benefit from more targeted treatment, especially treatments that have less toxicity compared to chemotherapy. This is very important for those patients and also for their family members and patients who don't have the cancer yet, as Jen said, to inform their risk.
Let's stay a little bit on the treatment factor. So we understand that it informs risk. How does it guide treatment decisions for men with prostate cancer? What's the role of genetic testing there?
Yeah, that's an important question. We have actually a group of drugs, and those drugs act particularly on the gene that's being affected by that abnormality in the whole DNA. And that gene is important because it protects us from developing cancer. So when this gene is not working, this means that our risk of developing prostate cancer or other types of cancers that are associated with this gene increases. Now, there are a group of drugs that work exactly where that abnormality is, meaning we don't have to treat a tumor, for example, with chemotherapy, and we know all the side effects associated with that. So when we provide targeted treatment, we have more effective treatment, so that will improve maybe progression-free survival or improve overall survival for those patients. And also it reduces the toxicity associated with treatments. We all know all the side effects associated with chemotherapy.
Absolutely. I mean, and that's an important distinction to make right at the top of the discussion that we're having. We also know that genetic testing has far-reaching implications, not just for the individual, but for family members as well. So perhaps you can talk us through what it might mean for family members, why cascade testing is becoming such an important part of the conversation.
Yeah, cascade testing is something that we use to describe this process where we find the original person who's got the high genetic risk of disease. Often we find that first person because they've already had a cancer, and we do a test in them to say, oh, is there a genetic cause for this? Then we cascade down through the family tree to say people in their family are also at risk of this because genetics is hereditary, it's passed on. And often for things like cancer predisposition causing mutations, these are things that are inherited by 50% of the family members. And so this is something that is really significant for family members, and they should be offered genetic testing to see if they also have the same mutation. It's not always done very well. It's an area that I would like to see greater uptake and a greater focus in Australia on how do we find those people? How do we make sure that they are getting that information about access to testing? How do we make sure that they can access this information? But for them, it can actually be preventive. You know, for the first person who's already had the cancer, we can't prevent that. It's too late. We can hopefully try and treat it, but we can try and prevent or detect early cancers in family members. And so that cascade testing is really important. But beyond that, we are also looking at how do we look at the general population, and how do we look at how screening might skip that reactive step altogether, rather than waiting for someone to have cancer and then testing them and then testing their family members. It's now, we've done modelling that shows it's cost effective, the cost is coming down. We should be looking at screening the entire population for this kind of genetic risk and getting to young people early before we even have that first person having that predisposition, having a cancer. And then we can test family members. And so it's even another step ahead of what we're doing at the moment, is trying to get to the population earlier and more effectively.
And I think it's important we're surfacing conversations like this one today, right? Because it brings to the fore unpacking what this really means for men with prostate cancer, for families that might be facing any type of cancer diagnosis that's linked to genetics, because there's a lot of perhaps uncertainty. People don't want to be tested. They don't understand the implications of testing. And I think that it's important that we talk about it today. What would you sort of say to those who might be tuning in? And again, I take that lens of sort of hearing about this concept for one of the first times, because there's a lot of unknowns. So what assurances do we have for people that might be tuning in that this is a good thing, that family members should be tested? I mean, I know that there's that feeling like, I don't want to be tested, I don't want to know, but there's so many benefits that we've already started talking through. But yeah, what would your assurances be to maybe some of those people tuning in today?
Definitely some people take the attitude that they would rather not know, and some people choose not to have genetic testing because they don't want to know about risk of medical conditions and risk of disease. That is a personal choice, and we would never coerce people to have a genetic test. But I think it's important to be clear that the kind of things we were talking about here are things that you can do something about, and whether that's preventing altogether or if that's catching at a stage that is earlier and more treatable. Yes, someone might say, well, I can't do anything about it if I've got a risk of cancer, but actually sometimes you can. And the question really is not, would you rather just know about something you can't control? It's, if you could have gone back and prevented this or caught it at an earlier stage, if you could have been alive rather than on death's door, would you wish you'd had a different option? And so offering people this kind of opportunity to have testing is all about taking control, knowing about risk, and being able to take steps to mitigate that risk for people who, if they don't have that opportunity, might be in a position of saying, well, I wish I'd known. I wish I could have done something. I wish I wasn't on death's door. I wish I didn't have a stage 4 cancer diagnosis. Not everyone will want testing, but certainly we need to be offering people the opportunity to have that kind of testing who do want to be proactive, who do want to take steps, and who do want to understand their risk in order to prevent disease.
Haitham, you're nodding along there. Do you want to add anything to this answer for this question?
No, I totally agree with that. I think it's very important to encourage patients to consider genetic testing. We, of course, respect their choices, but I think creating awareness about the importance of the testing for the individuals and for their loved ones, I think is very important because it could be life-saving for certain people.
Absolutely. Let's talk about your research too. So it's the first national consensus study in this space. Talk us through the key findings. What do they tell us about how genetic testing is currently being used in Australia?
Yeah, actually, this study is part of a group of studies that we conducted as part of a research program funded through the PCFA. So we looked at international guidelines and local recommendations about who should be tested for genetic testing, and then we looked at what a group of people think between patients, caregivers, and healthcare providers to look at their perception and consensus around those recommendations that we've summarized from international guidelines. Unfortunately, we don't have in Australia national guidelines for genetic testing in prostate cancer. We have a set of recommendations coming from AVQ, but we don't have national guidelines. So what we got out of that study is that the majority of the patients, consumers, and family members were positive and open to receiving genetic testing and sharing this information with their loved ones and encouraging them actually to take the test. So that was a positive thing. They also preferred to have more engagement with their healthcare providers, particularly with genetic counselors. They appreciate the value of learning more about that mutation, if it is detected, and what it means for their treatment pathways and what it means for their risk of developing cancer if they haven't developed cancer. And then we also looked at clinicians' perspective was a little bit different because many of our clinicians, they practice evidence-based medicine. They want everything to be based on evidence. And currently there is some uncertainty in who should be tested, how they should be tested, and when, and the pathways for genetic testing in practice. So these are the key findings. We followed that study with some modeling of different scenarios of genetic testing, like genetic testing people with advanced disease, testing people who have high risk but they don't have the disease yet, also expanding testing to their family members through cascade testing, and we've identified which scenarios are value for money for our health system.
Excellent. I mean, great summary of the research, and we'll delve into deeper parts of it. You talked about patients being ready for broader access, but clinicians we know need clearer pathways and support. Why is there still so much uncertainty in the system?
Because I think it's basically we don't have national guidelines to provide clearer, I would say, guidance or evidence-based recommendations for the clinicians. We have a set of recommendations, but we need maybe to expand those recommendations and update them regularly. So that's one aspect. The other aspect is funding and access to those tests, because currently we don't have reimbursement through Medicare for all of those tests. So we have the testing for receiving the drug is subsidized, but testing people just because they have advanced disease, or people who are at risk, or people with prostate cancer who have an early stage, that's not currently funded through our health system. So I think it's a combination of guidance through guidelines and evidence, access to healthcare through the reimbursement channels, and also we've identified some sort of disparity between regional and metropolitan areas in terms of the facilities and the labs available to conduct those tests. And genetic counseling also was a a main issue because referring patients to genetic counseling is an important element of care when they do genetic testing, and we need also our health system to be ready to provide that service.
I think more broadly, one of the things that is worth thinking about is that structurally, overall, we don't have a health system that looks at genetics as a proactive or preventive part of healthcare. And one of the questions about increasing access to genetics really has to look at shifting that paradigm into an area where we see genetics as part of mainstream healthcare and part of prevention. At the moment, it's sort of seen as something where we wait for evidence about doing a targeted test in a targeted person for a particular reason. And if that doesn't exist, you can't do the genetic test. And because of that, we only have a small number of reimbursed tests, and they're only in very narrow use cases because we're targeting a certain drug or because someone has had, a specific kind of cancer. We don't yet say this is of value to the population, both in an economic sense and in a medical sense, to find out about these things beforehand. And many of those things flow from that. The reimbursement pathways aren't there because we don't see that as something that we should be doing at the broader population level. We don't see clinicians doing it because it's not something that is part of clinical care. And so we really have to shift into this idea of genetic testing is now cheap enough, it is at a cost that it should be able to be available more broadly to the population, but we have to shift into a mindset that genetic information is part of preventive healthcare, it's part of primary care, it's for healthy people, it's for people to understand and get ahead of risk, not just for these really tiny use cases, which historically were sort of left in that category because it was too expensive to do it across the population.
Yeah, it's important to talk about that, the whole system and the structure there. PCFA has also called for a national framework to guide genetic testing. From both your points of view, what would that look like in practice, and why is it urgently needed now?
Yeah, I think the key question is who should be tested, when, and how. If we could, I think the framework should provide that guidance about the evidence required and the pathways for those patients and non-patients as well, if they choose to be tested. The framework should look holistically at our health system. It's not just about the test itself, but also the supportive care around that, including genetic counseling and any downstream implications of testing. So if patients wants to get prevention because they've identified high risk, they might need surgery if they are ladies and they want to prevent or protect themselves against breast cancer or ovarian cancer. So it's the framework needs to be holistic, providing set of recommendations and guidelines, but also in a pathways of care where we bring different components of the health system together in an integrated way and ensure that our health system is ready to provide that service at scale.
I think we actually need to just start doing more testing. I think obviously it's important to have frameworks to guide where we're going. We've had lots of frameworks about genomics in the past decade. Genomics Australia is working again on a framework and they're refreshing the population-based screening framework at the moment. However, we are not seeing action in terms of actually funding projects that move ahead with boots on the ground genetic testing and moving into clinical care. And we like to talk about frameworks, but what we need to do is actually be doing more genetic testing. And there are things like the BRCA gene, which is one of them, BRCA1 and 2 are two of the most common genes that lead to a high risk of prostate cancer in men. We've known about the BRCA genes for decades. And this is not new information. This is not, shiny, new, unknown type of things. We know about risk. We know about the recommendations for what to do when someone has this kind of risk. We should just be expanding access to this kind of genetic testing. We don't really need more evidence for that. We do need to ready the health system, but health systems also don't get ready for new programs in a vacuum. And certainly the health system isn't going to just sit around and prepare itself for population genetic testing at scale without any actual genetic testing happening in the population at scale. We need to move that through the system. And so through the DNA screen study, we did a pilot study of 10,000 people. We did that through an MRFF funded project. It was very successful. We found about 1 in 50 people had a high risk gene across breast and ovarian and prostate cancer, as well as Lynch syndrome, bowel cancer, and heart disease genes. But we found through that study about 2% of the people, so there were 200 people. We've shown that there's clinical benefit. We've done cost effectiveness modelling of rolling this out to the whole population. And now we're saying to the government, we need to actually just expand access. And through an expanded program where we test more people, we can do some of that health services research. We can develop and test the models of care. We can get the health system ready, but the health system doesn't get ready by writing a framework. Workforce doesn't get ready by sitting around and talking about the fact that workforce will be needed when we do this kind of testing if it doesn't exist. And so I very strongly feel what we actually need is a commitment to and an expansion and a funding of programs that increase access to testing at scale in a responsible evidence-based way, so we can actually gather the evidence, we can actually provide clinical benefit to people over the next 5 years. And ideally, by 2030 or so, we should be looking at how do we introduce a screening program using genomics for disease prevention. But we can't get to there without actually doing those steps of actually doing it clinically.
Haytham, let's go back to your research for a moment, because I don't want to move on too quickly and miss some of the key findings that I think will really benefit people listening. One of the most important findings is that earlier testing delivered the greatest health benefit. Can you talk us through what that means in practice, particularly for men with metastatic or high-risk disease?
Basically, genetic testing currently is highly recommended for people with advanced disease, and at that stage, it's often to guide treatment with targeted therapy. But if we identify patients early at their journey, maybe with better testing, we can tailor treatment and management in a way that we prevent or delay disease progression. So that is basically the value that we will get out of early testing. And the earlier we know about the risk, the earlier the cascade testing can take place, so we alert other family members about their risk. Any delay in identifying those risks, I think, will result in health and also economical impact on our health system. I think it's also important to identify some populations that are at higher risk than others, and that they could benefit from early testing, such as patients who have, or not patients, individuals actually, who have family history in the family, so their parents or their siblings, they have developed cancer, so they are at higher risk. And in this case, we definitely encourage them to do the testing. People coming also from certain ancestry backgrounds, like Ashkenazi Jews, also will, it's well known, for example, they have high risk of the BRCA genes, and they could benefit from the testing. So I think the earlier the testing is done, the better, to achieve for the prevention, and also to tailor treatment for the patients who have the diagnosis in order to prevent disease progression.
Excellent, and thank you for that clarification and the expanded understanding there of your research. Jane, back to you, and let's shift gears a little bit, talking about the life insurance and obviously the recent reforms in Australia, because we've had concerns about genetic discrimination, particularly in life insurance. That's been a major barrier for many people. Why has it been such an issue? And then we'll get into what's changed and what it means for the future. But yeah, why has it been such an issue for people to date?
Yeah, so obviously when people are considering having genetic testing, whether that's in a research context or a clinical context, whether they've got cancer or a family member's, being tested and then offered testing, everyone who has a genetic test has to be told about the consequences or the potential consequences of testing. And that's part of informed consent for any medical procedure. And for decades, we've had to tell people one of the potential consequences of having a genetic test is that if we find that you are high risk and you go to take out a life insurance application, you will potentially have to tell them, if they ask you, you have to tell them about that genetic test, and they can legally use genetic test results and the risk shown in those genetic test results to discriminate. And when I say discriminate, I mean deny you cover altogether, increase the cost of your premium above what it would be if they didn't have that information, or put conditions on your cover, choose not to cover certain things as part of your policy. And so people hear that and they think, well, that's actually not a good outcome for me, and maybe I don't want to risk my financial future. Maybe I'm worried about what that means for my kids. And often we see people either say, I don't want the test, I don't want to be part of this study, I'd rather not know because I don't want to mess up my future insurance. Or they say, I'll go away, I'll look into it, I'll sort out my insurance and I'll come back. And maybe they come back and maybe they don't. Maybe they forget about it. Maybe it all becomes too much. Maybe they can't sort out their insurance. And we see many, many people being deterred or delaying or declining testing because they're worried about these implications for their life insurance. It is the most significant issue we hear. We hear it always from clinicians, from researchers, from anyone who's involved in the space. It takes up time in consultations, and it's this big headache that always has to be dealt with. Whenever I am in the media or on talkback radio and we talk about genetic testing, people will ring in and say, what about insurance? They're really concerned about it. It's the biggest reason that people who wanted testing through DNA screen ended up dropping out. When we surveyed people who ended up declining, more than half of them said, I wanted this testing, but I didn't go ahead because I was worried about insurance. So we know it's been this really significant deterrent, and the most significant, not the only, but the most significant concern people have about why they don't want to have testing if it's something they're otherwise interested in.
Then let's get into the legislation, because we talked about it being a major step forward. This is really important. So Australia has now passed the legislation to ban the use of genetic test results in life insurance underwriting. What exactly has changed?
Yeah, so for many years, we're talking about life insurance here because health insurance in Australia actually works differently. So health insurance is community rated, and that means when you go to take out health insurance, they can't deny you cover or increase the cost of your premium on the basis of any health risk, be it genetic results or anything else. You might get a waiting period applied if you have a pre-existing condition, but they can't actually say, oh, your cover's going to be more expensive for health insurance than someone else's because of these health things. But life insurers can. Life insurance is risk rated, and that means that they take into account any kind of risk, whether it be medical risk, family history, or genetic information. And that's been part of the law. So we have a law called the Disability Discrimination Act. That act actually bans discrimination on a number of health fronts, including genetic status. But there's a special carve-out, an exception in that act that allows risk-rated insurers, as long as there's evidence to support what they're doing, to discriminate on the basis of health information, including genetics. And so I've been working for almost a decade now, since 2016, on trying to get that loophole closed and get that law banned so that people can't be discriminated against on the basis of the genetic results when they go to take out life insurance. Now, it's been a long journey, but in April of this year, we actually had a law finally pass through Parliament. It's come into law. That means it's in force. But the ban part of it, which is Schedule 1 to the Act, actually doesn't become enforceable until the 8th of October. So there's a 6-month period between April and October 2026 where the insurers can get their ducks in a row and get ready to comply with the law. And from October 2026, they will not be allowed to use genetic results to discriminate.
And then, well, congratulations, first of all, and it's fantastic news for people listening. What do you expect this to have in terms of impact? Obviously, it will cause more confidence. There'll be uptake of testing. What do you expect in the coming months and years?
This will have really significant impact. Now, the measurability of that impact will be challenging because you can't actually draw a direct line between the number of tests that have been had. And also we expect that in the coming decade, the amount of genetic testing will rapidly increase, and the access to testing and, programs that do offer genetic testing at the population level hopefully will become more common. And so it will be hard to say how many tests would have been done if this wasn't in place. But we do know what a barrier it is. We do know how many people tell us about patients who don't get testing, people who are concerned. We know people that dropped out of our study because they were concerned. And so every single offering of a genetic test in Australia will no longer have to say to people, you need to worry about your life insurance, and is that something you're concerned about before you have a genetic test. Now, doesn't mean everyone will have testing. Some people will still decline testing for different reasons, but removing that barrier really significantly changes the risk profile for most people, and they will be able to make a decision about genetic testing based on whether they want that test, not based on whether they're compromising their future insurance. And I expect that that will have a really significant impact in all of those contexts, both on the time taken and that consent process, which can just focus on medical care, not insurance problems, and on people's ability to make that decision and not have to have that at the back of their head.
Excellent. Well, we have had very wide and varied conversations so far on genetic testing and these recent reforms. Let's look ahead. So we talked a lot about policy and system change. Haytham, I'll bring you in at this point of the conversation. What policy and system changes are still needed to ensure equitable access to genetic testing across Australia? And maybe taking that forward-looking view, what else would you add to that in terms of what you'd like to see in coming years?
Yeah, I think it's very important to expand coverage through Medicare to cover as much patients, as many patients as possible, and as much conditions as possible. I totally understand the constraints that are in our budget, and I think this is something that we need to be clear about when we talk to decision makers. So while I understand the need to expand funding, we have the evidence about its value for money. So there is a clinical need and there is value for money already demonstrated. And I think working with decision makers to expand that coverage, I think, is a priority, because that will improve access, and patients don't have to pay out of pocket for that. And the other thing I think is about looking at all barriers and facilitators and any issues about disparities that we have between different geographical areas, and ensuring that we have enough workforce and capacity to deliver those services where they are needed. We also have communities that may benefit from the testing, especially people coming from different linguistic and cultural background, that we need to create that awareness to enhance equity among all Australian populations.
And Jane, from your perspective, in terms of the future policy system changes that are needed?
Yeah, obviously the genetic discrimination legislation is the most significant sort of ethical health policy, legal policy that we needed changed, and it's really exciting that we're there. And that change really paves the way for more broader sort of system change and policy shift. And as I was saying previously, what I think in terms of policy change is around that mindset and paradigm shift from a reactive way of looking at genetics into a preventive, primary care, population health, public health way of looking at genetics. I think the government needs to see this as an opportunity to invest, and they need to see it as something that is not a little niche area for people with certain sicknesses, but something that is applicable across the whole population, something that is applicable across all types of medicine and healthcare, and something that should actually be a high investment priority. At the moment, there is interest in genetics. There is funding around the edges. Genomics Australia has been set up, but we really haven't moved into an area where the government is recognising the true potential of genomics, what it can do, and what an investment it is, and really putting money into actual projects. And that's what I think we need to see.
Let's talk quickly too about support. We talked about genetic counselling earlier in the podcast. For men and their families who are listening, where do they go for information about genetic testing or to get support if they're considering it and going on this journey? Haytham, you first.
Yeah, if you talk about prostate cancer specifically, of course, Prostate Cancer Foundation, they provide important resources. We have a helpline, and we have specialized nurses program that through telenursing that is accessible to patients. They can seek that help. Also, they can talk, of course, to their GPs and their healthcare providers as first point of contact for them. I think that would be the safest way for them to engage with healthcare providers at this stage.
And Jane, recommendations from your side?
Yeah, I think if someone already has prostate cancer in the family, or for themselves, obviously they can reach out to their healthcare providers that are looking after their care. GPs can provide referrals to genetic services. People can reach out to genetic services directly, but often they will be required to go back to their GP and get a referral to kind of make the specialist pathway work. I think if people are interested in finding out about their risk, but they don't already have prostate cancer in the family, but they worry that this might be something, or they can't get access to testing because they don't have enough family history to meet criteria, then it's really a matter of looking at what are the opportunities. We have a proposal in with the government to fund greater access to testing through DNA Screen. We have an MP campaign where people can write to their MPs about more access to testing. And so if people are looking more at the policy side of trying to encourage the government to increase access to this kind of testing, then they can go to the DNA Screen website. They can fill in that form. But certainly if there's someone that's already affected, going to their GP, going to the Prostate Cancer Foundation, and getting a referral to genetics are their best pathway.
Excellent. As I said, we have had a wide and varied conversation today. We've covered a lot in the podcast. Just in the last few minutes, maybe last closing remarks from both of you. Maybe you want to re-emphasize a point you made earlier, or tell us a message that you haven't yet covered. What do you want viewers and listeners to leave with from this podcast today? Haitham, first to you.
Genetic testing is important. It saves lives. And I think we need to invest in genetic testing broadly to prevent disease and improve health and well-being.
Brilliant. And Jane?
What he said, genetic testing saves lives. This is, we talk about preventive health and people think about really broad programs that maybe aren't really specific to certain people and trying to, sugar tax and things like that are important. But when we talk about preventive health, we say, I can tell you who is at risk. I can find the person for you. I can deliver them to preventive care. I can prevent cancer and I can save lives. And that's the kind of prevention we need to start moving towards. And genomics is the way we can do it.
Excellent. Thank you to you both. It has been a privilege for me to host this conversation and to have your expert views. And I know that there would have been a lot of value there for listeners and viewers today. So thank you for coming on the Prostate Podcast. Thanks a lot.
You're having us. Thank you.
We've been speaking today with Professor Haitham Tafaha and Dr. Jane Tiller. We want to thank them for sharing their expertise and helping us better understand the role of genetic testing in prostate cancer care and what recent legal reforms mean for Australian patients and families. You heard it from them, but I'll reiterate right now too. If you want to find out more information about genetic testing or prostate cancer support services, you can speak with our telenursing service on 1-800-220099 or visit prostate.org.au. Thank you so much for tuning in, and we'll see you next time.